So you snore or have sleep apnea. What now? My name is Dr. John Viviano. I've prepared this little video for you to watch. Make a note of any questions you may have, and I look forward to seeing you soon.
Sleep is a basic necessity of life, but even more important is breathing. When you sleep, air travels through your nose and mouth, down the throat, and into your lungs. The narrowest part of the airway is at the junction where the soft palate, the tongue, and the back of the throat all compete for the same space. When you are awake, the muscles are tight, keeping the airway open. But when you sleep, these same muscles relax, causing the airway to narrow. As the air passes through the narrowed opening, the uvula and the surrounding tissues begin to vibrate, causing a condition known as snoring. If the tongue continues to fall back, it will cause the breathing to become slowed or completely stopped. This is known as obstructive sleep apnea. Sleep apnea can cause fragmented sleep, shorter lifespan, reduced quality of life, and even death. A comfortable and effective option for treating obstructive sleep apnea is with a custom-made, removable sleep appliance that a dentist trained in the treatment of sleep apnea can provide. With the sleep appliance in place, the lower jaw is prevented from falling back, keeping the tongue forward and the airway open. Often this will reduce or eliminate snoring and sleep apnea, providing the body with deep, restful sleep.
It's important to understand the consequences of not managing your sleep-disordered breathing. To the quality of life, cardiovascular issues, hypertension, stroke, heart attack. Then there's diabetes, glaucoma, hearing issues, you're more accident-prone, lack of energy, relationship issues, mood issues, loss of libido. And as the video said, there's an implication to your lifespan. Basically, unmanaged OSA shortens your life. Implications to your bed partner. Managing your snoring and sleep apnea will improve your bed partner's sleep, equivalent to give them an extra hour of sleep per night. That's in fact how much you're influencing negatively their quality of sleep in an unmanaged situation. The most conservative therapies are CPAP, continuous positive airway pressure, and an oral appliance. With CPAP, pumps air into your nose, down your airway, pneumatically splinting your airway open. Very high success rate. 90% plus of the time, they'll get the apneic events down into the normal range. However, only about 2/3 of patients can comfortably tolerate wearing this device, and about half of those are wearing it all night long, and the other half are taking it off part way through the night. So this results in an average use of about 3 to 4 nights per week and 3 to 4 hours per night. Adjusted nasal CPAP effectiveness that takes into consideration both how effective it is and the time it is used is about 50%. With oral appliance therapy, which we saw in the video, holds the jaw forward, helping to maintain the airway, success rate is lower, 56 to maybe as high as 75%, depending on the outcome criteria you're trying to accomplish. But 90% compliance, 90% of the time plus, patients will wear their oral appliance, and if they wear an oral appliance, they typically wear it all night long. The resulting improvements to health are similar with PAP as they are with an oral appliance. This is thought to be due to the fact that patients wear their oral appliance more than they wear their CPAP on the average. In fact, the adjusted oral appliance effectiveness is about 51%. According to the current guidelines, after a sleep study and a board-certified sleep physician evaluating the results, you get a diagnosis, and then you get recommendations. Basically, Sometimes it's as simple as behavioral changes, losing weight and no longer sleeping on your back. If there's simple snoring involved and that's persistent even when you sleep on your side, well, oral appliance therapy is first-line therapy. If there is any level of sleep apnea, mild, moderate, or severe, CPAP is considered first-line therapy. However, if the patient cannot tolerate CPAP or prefers an oral appliance to CPAP, then an oral appliance is considered a standard of care for all apnea severities, mild, moderate, or severe. With an oral appliance, it can either be the full journey or the beginning of the journey. And what I mean by that is this. With CPAP, chances are very high that they'll be able to manage the apnea. Issue is adherence, the patient actually wearing the device. So they try different masks, and sometimes it will reduce the pressure to make it more tolerable, or go to an autopap, a different machine where the pressure ramps up and down, and that's all in an effort to try and get the patient comfortable with wearing the CPAP. With an oral appliance, 90% of the time plus, patients will wear their appliance long term. So we have another issue. The issue is, did we get rid of all the apnea? And so when we don't, then the patient can, with time, tolerate further advancement, so we can try advancing further and seeing if moving their jaw further forward will help, or we can try moving the jaw to a different vertical, a little bit more open. We can try implementing adjunctive therapies like positional therapy. Have the patient learn to not sleep on their back along with wearing the appliance, or implement weight loss along with wearing the appliance. Sometimes even combining an oral appliance with their CPAP machine is the answer. Lifestyle changes that will help to improve quality of sleep, sleep hygiene, and surgery. Sometimes some surgical intervention of the upper airway tissues will help the cause. And a new technology, neuromuscular stimulation of the tongue, to help make it fitter and help it behave more appropriately so that it doesn't fall back into the airway. So the appliance is either the full journey if it takes care of the problem completely, or the beginning of the journey, and these other modalities can be used adjunctively along with the appliance to help take you the rest of the way. So neither CPAP or oral appliance therapy is a magic bullet. Clearly with CPAP, the Achilles heel is compliance. Will the patient wear it? So I encourage you, if you're going to try CPAP, to trial it first rather than accepting it up front, because it has insurance ramifications. If you have insurance coverage for either CPAP or an appliance, and you've accepted the CPAP and have the insurance kick in and cover it, now you've lost any opportunity to have insurance coverage towards an oral appliance for a period of years. So if you trial it and establish whether you can comply with it first, this would be in your best interest. The Achilles heel with oral appliances, is it effective enough for you? Because this varies greatly from patient to patient. The good news is that we have tests where we can actually evaluate to see whether an appliance will work even before we make an appliance. So there's no need to provide an oral appliance without knowing whether it'll be effective ahead of time. Sometimes, in the end, the best outcomes are from combining various therapies. So collaboration is the key, whatever it takes for your particular situation. You stop breathing at night, your airway's compromised, you're medically compromised, your quality of life is compromised. We're trying to find a solution, whether it be one device or another, or a combination of therapies. It's going to be unique to your own personal needs. If you'd like to read more, there's a free ebook download on stdacademy.com. There's my email address if you have any questions after the consultation. I look forward to seeing you soon, and hopefully this little video has prompted some questions you may bring into our consultation.